go. And we are underway.
Okay. Thank you for joining us today for Nursing Grand Rounds. My name is Victoria Lancy, and I'm the Education Manager for Michigan Center for Rural Health and will be helping facilitate today's program. This program is jointly provided by the Michigan Center for Rural Health in cooperation with the Michigan State University College of Nursing. This program will provide nursing continuing education, and if there are other healthcare professionals on the line, you can receive a certificate of participation. Please remember to keep your mic muted until the Q&A component at the end of the program. Please remember to mute your mic after you have asked a question so the signal is clear. Handouts are located on our website at www.mcrh.msu.edu. Click on the education link across the top and then scroll down until you find September 7th. Attendance forms will need to be filled out by hand, and then don't forget that you are required to complete the attendance form and then fax, email, or mail it back to our office, and then complete the evaluation online via SurveyMonkey. Certificates will not be sent out unless both the attendance form and evaluation have been completed. We are asking you to complete and return these forms to the Michigan Center for Rural Health office within 2 weeks or by September 21st. Remember, certificates will not be emailed most certificates usually take 6 to 8 weeks to receive. The speaker and planning committee indicate that there is no conflict of interest for this program and there is no commercial support has been provided. At this time, I am pleased to present our speaker, Dr. Kara Schrader, who will be speaking on depression screening and early treatment. Go ahead.
Okay. Hi, everybody. This is just a listing. This is just a listing of the objectives. You can read those on your own, but pretty much I just want to go over the importance of screening as well as the reasons why possibly we're not screening. And with any time we screen for depression, follow-up is really important. And when we screen routinely, we can start early in an initiation of treatment. And I want to talk about the importance of that. So major depressive disorder really is, according to the WHO or the World Health Organization, the leading cause of disability in the world. There's a lot of burdens associated with depression, especially if it's under-recognized or under-treated. The burdens are not only with the person that has the depression, but also with their family and society in general. People with depression tend to have decreased work productivity, which affects society. Substance abuse risk is higher. Disability, of course, due to depression, unemployment, and of course there's higher rates of suicide. Economically, in the U.S., $173.2 billion was spent in 2005 for treatment for depression. And then it increased significantly to $210.5 billion in 2010. These figures, I understand, seem old, but it takes a while for them to look at these figures. So really the financial burden, as you can see here, significantly increased in 5 years, and they do say that it is increasing steadily. 5% of our gross domestic product is in the U.S. is spent on mental health care, and this is in the form of absenteeism. These are just reasons for the gross domestic product and the reason for the financial burden. So absenteeism, which is missing work, of course. Presenteeism, when somebody would go to work and not produce like they should. The cost of suicide are tremendous. The inpatient and outpatient visits, as well as the pharmaceutical cost for depression. The treatment for depression can be education, psychotherapy, and medications, as you probably know about. And figures have shown that for every $1 in treatment for depression or anxiety, there's a return on investment of $4 for every $1. And so I can break that down a little bit. So for 6 months of medication, if the person has moderate to severe depression, is more cost effective than having the person not getting treatment. For 4 years or 4 years of moderate to severe depression, 14 to 18 visits plus antidepressants, intensive psychosocial treatment. These are also more cost effective than the financial burden from untreated depression. The money that is saved, of course, is the increase in productivity, the decreased absenteeism, as I mentioned before, was a problem. Also improved quality of life. They can estimate this with particular equations to determine the cost of improved quality of life years, and also less expense on chronic illness treatments and mortality, and less risk of suicide completions and attempts. So let's just look at the amount of people that are estimated to have major depressive disorder. 6.6% of the adult population, it's estimated, has major depressive disorder, or at least has stated they've had major depressive disorder in the last 12 months, though only a third of them obtain treatment. And these figures are from the Substance Abuse and Mental Health Services. It's a survey that they did in 2014. They are also called SAMHSA. You might know them as that. And the reason treatment is not obtained, it's stated that because of the stigma associated with depression or mental illness, short appointment times, really it's difficult to get or tell the provider everything you need to tell them within short appointment times. And it seems like these times, especially in primary care, are getting shorter and shorter. There's also cultural assumptions when it comes to depression. There are certain cultures that live within the U.S. that will not discuss depression. They feel like there's more stigma, even more so in certain cultures than others. And depression really presents differently for different people, and so that's another reason to screen. Often it coexists with anxiety symptoms, so it's really difficult to differentiate between anxiety and depression. Really, getting the diagnosis of depression early on improves treatment and can prevent those adverse outcomes that I talked about earlier with absenteeism, presenteeism. There is an association with increased morbidity, meaning worsening sickness, along with coexisting chronic illnesses. I'm going to go over some of what that means. So with cardiovascular disease, there really is a higher morbidity or greater sickness with the diagnosis of cardiovascular disease, as well as an increase in mortality. In addition, people with chronic pain, and this is really interesting, people with chronic pain are 2 times more likely to be treated with opioids by their primary care provider and misuse the medication by increasing the dose on their own. There's been other studies that have shown that people with depression have a higher tolerance for the opioids. So again, they're wanting to increase the dose to treat their pain. Researchers Kapoor and Thorne looked at federally qualified health center encounters that were primarily for pain, and persons that had the diagnosis of depression within the charts that they audited or looked at were more likely to have a prescription written for opioids to treat chronic pain than those that did not have the diagnosis of depression. Interesting stuff. Now with COPD, as you know, that's quite a lifelong, once it's diagnosed, debilitating illness with a great risk of developing depression. And after reviewing a lot of studies, And there was a really large review study. They found that association with depression increases the risk of COPD exacerbations. And it was surmised that with these exacerbations and coexisting depression, there were more hospitalizations because of the exacerbation and increasing the mortality risk. There's just been more and more being published regarding the association of dementia and depression. This is really interesting, and I've been following the research on this because they're still trying to understand what the pathophysiology is behind this increase of risk of dementia. But within the studies, they're estimating that with 2 or more episodes of depression, it doubles the risk of getting dementia later on. Of course, we've known quite a while that diabetes outcomes worsen with depression, and in all chronic illnesses, as well as those that aren't mentioned. The importance of screening and adequate treatment early on is really important for decreasing that morbidity or improving outcomes, and of course reducing the mortality because the chronic illness is being better taken care of. So I'm sure you're familiar with the criteria from the DSM-5 for major depressive disorder. I don't really need to read through those, but what's really important from this, if you're not aware of it, is that at least 5 or more of these symptoms need to occur every day, pretty much, within the same 2 weeks. And it cannot be associated with grief or substance abuse. Those things need to be ruled out before you can actually make a full diagnosis of depression. And pretty much depressed mood every day, as I mentioned. And you are, most likely you use the PHQ-2 and 9 if you're in primary care practice. And so, as you can see, most of these questions have to do or are associated with the questions that are on the PHQ-9. So the screening recommendations by the United States Preventative Task Force, and they continue to recommend, the latest recommendations were last year in 2016. They recommend screening for depression routinely in ages 12 and up. And the American Association of Family Physicians does as well. American Diabetes Association recommends routine screening, and then screening again if there's been a change in the diabetes or an increase or worsening of symptoms. And then the Institute for Clinical Systems Improvement, they worked with the American Psychiatric Association to develop guidelines for screening and then the management, and we're going to talk about that in another slide. But they worked together to develop the guidelines that we know today. Of course, all recommendations, if you're going to screen, and I will say this probably several times, you have to have a system in place for follow-up. So if you have a positive screening and you have nowhere to send somebody for a treatment, and you don't feel comfortable with that treatment yourself, you really should not be screening. So this is more of our primary care talk, but it can, a lot of this information can be applicable to other types of organizations. But long ago in 1996, the Institute of Medicine stated that primary care pretty much is responsible for all the needs of the patient, and that includes mental and emotional health as well. And there's that quote there from the IOM's book from '96. So screening in primary care settings, primary care providers have more opportunities because they have more contact with the patient. They've built a trust. They know, often in family practice, they know the family. The family may be their patients as well. They can assess the social determinants that are within the community as well as the patient themselves to address any of those determinants they may be affecting their life and increasing the risk of depression. And they also can form linkages to resources within the community to help for effective treatment. As you know, and I stated earlier, conditions such as depression and anxiety are pretty much managed in primary care, and it takes the team approach. And we're going to talk about collaborative care further on in the slides, but the team approach for screening, and this is staff, this is referral staff, this is the provider, this is any nurses, medical assistants within the clinic. It takes a team approach to increase screening. The study that I have listed here was taken from data from 2012 and 13, showing that only 4.2% of adults were screened in the primary care setting for depression. The data was taken from the National Ambulatory Medical Care Survey, which it's quite an important survey, and it's usually published on the Center for Disease Control and Prevention's website. But they looked at 33% encounters to get that figure of 4.2%. I do anticipate, though, and I think that just from other readings, nothing definite, that this percentage probably is a bit higher now with the implementation of the electronic health record, because we do get this pop-up when they are due for their depression screening. Or if they're due for, if they have the diagnosis of depression, we get a pop-up to reassess that. So I'm hopeful that the electronic health records, although there are some annoying things with that, that it will help with the screening of depression. I realize that some of you are in rural health centers or federally qualified health centers, so the merit-based incentive payment system doesn't really pertain to you, but maybe some of you are not. This is the PQRS from Medicare, and this is what they changed PQRS to more of a quality program, and then changed it to this MIPS acronym. And this was just in January. So it is just a different program, as I said, to assess quality. And there are several performance categories that do pertain to depression and mental illness within this merit system. The priority items I have on this slide have like a plus sign. Those are the priority ones that they want us to look at now. And if you see that there, suicide risk assessment for adults and children that do have major depressive disorder is one of the priority items. And assessing for remission in 6 months with PHQ-9, and they're defining remission of depression of less than 5. And then again, assessing for remission with the PHQ-9 at 12 months. So, that MIPS is another reason for, the quality improvement directors to design programs to improve depression screening, but more importantly, the care after a positive screen. So why aren't we screening? Why are the percentages so low? The workflow for screening and the follow-up really is essential, and that's the third time I said it, so it's pretty important. And then changing or adding anything or any more responsibilities to staff is difficult. It seems like every month we're asking the staff to do more and more because the appointment times are shorter, and we need to get lots of information ahead of time before the provider can enter the room. And people with chronic illnesses, especially more than one, are really complex, and the focus is more on their physical disease rather than their mental health needs. And depression screening isn't universally reimbursable by insurances. Medicaid doesn't reimburse for it. Medicare does reimburse for it. It's, last I look, I think it's $45 for screening once a year. But the requirements to get that reimbursement is meeting face-to-face with the patient for at least 15 minutes. And if it's a negative screen, 15 minutes, it doesn't take 15 minutes, especially when appointment times are 20 minutes, that would take quite a bit of time. And not all the private insurances will reimburse for depression screening. In my organization, I'm a nurse practitioner in a family practice site at MSU here. We don't bill for depression screening because it's not universally covered. You can't bill Medicare for depression screening and then not bill Medicaid or private insurance. Because often the patients will get that bill. Of course, Medicaid patients would not, but the private insurances would. So understanding what services are available in the area for referrals is really important, and often the primary care offices or providers, referral staff, they're not aware of what's available in their communities, or it's just limited what's in their communities to refer for counseling or psychology, psychiatric help. So barriers to providing adequate depression care. Treatment to goal measures are really, really low in the primary care setting. There's been some research showing that providers are uncomfortable managing depression and just want to refer them out. And as I said, that's limited to refer out for depression. And primary care really is where depression and anxiety is managed. Not understanding that the guidelines for titrating depression meds can be confusing, and there may be a discomfort with that. And when there's chronic illnesses that are associated, this may make the healthcare provider a little uncomfortable with adding certain medications to the regimen for depression. The time is limited in a clinic appointment, especially if somebody has a depression diagnosis. So, mutual decision-making or shared decision-making takes time. And to educate the patient about depression and the treatments that are available is difficult to do in the limited time. There are lots of treatments for depression, including education and therapy, depending on the severity of the depression. And primary care providers tend to overutilize medications because that's easier to do than to do the education or refer to therapy, especially if there's a limitation of what's available in the community. Care management is key to managing all chronic illnesses, and especially depression, but it's not financially sustainable yet. We're still not getting the money that's required to pay for the care managers. Usually they're nurses or behavioral health specialists to maintain their employment. It is a requirement in federally qualified health centers to have care managers as well as behavioral health specialists available. So that may not be as much of an issue in some of those clinics, but it is an issue in those that don't have that federal funding. And when there is care management present, they tend to prioritize on other chronic illnesses, maybe hospital follow-ups, transitions of care, because transition of care is reimbursable. They also are given the responsibility to work the registry to improve population health measures, and the mental health follow-up for depression or anxiety doesn't always become priority. So the limitation of referring to behavioral health. In many areas, behavioral health provider access is limited. We're starting to get away from this across the country, though there still are some carve-out programs within insurances where certain health or behavioral health providers have to be used instead of ones that may be more available in the community. And when there is this carve-out system and they need to, these healthcare providers or behavioral healthcare providers, and I'm talking mostly psychologists and medical social workers that are licensed to provide counseling, they are overwhelmed. It's difficult in the carve-out system to only have a few that are selected to provide that care. The workflow for referring for behavioral health is complicated. In the state of Michigan, it just recently in August, the policy changed that we no longer need to have the patient sign it's like a behavioral health HIPAA form to share diagnosis and meds with counselors that within the community for coordination of care. It's still not on the MDA, the website for the Health and Human Services yet, but I have been speaking with the directors there that are in the mental health section of that part of the state program, and that they're going to send out some information on that, where if it's for counseling and coordination of care, that this type of HIPAA form is not going to be required. That's been a real limitation and barrier for referring to behavioral health. Now, substance abuse, I'm not talking about that today, but you do need to still have that behavioral health form signed for substance abuse sharing of information. There is a lack of knowledge amongst staff, amongst providers of what is really available in the community. There is a national shortage of psychiatric providers, and I mean providers that prescribe. And because of that shortage, many of them don't accept publicly funded insurances such as Medicaid and Medicare. We really struggle in the Lansing area to find a psychiatrist that will take Medicare and Medicaid. We've kind of figured out a system and how to do that, where they see a therapist for so many times, and then the therapist determines whether or not they can see the psychiatrist. But still, it's quite a limitation, and not all patients need to see a psychiatrist for mild to moderate depression. So for private insurances, though, it seems to be a lot easier. So Blue Cross and some of the other ones that are private through people's work seem to have better access to psychiatric care. So right there is a huge social determinant for our older population and our population that are lower income, the access to psychiatric care. Community mental health continue to get decreased funding. Here in our area, it's difficult to get even the Medicaid HMOs into community mental health unless there's a real severe illness like schizophrenia or attempted suicide, just because of the decrease in funding. And you can see the statistics there. It's most of the primary care providers nationwide report difficulty in obtaining access to psychiatric care for the reasons I just mentioned. So the screening tools, most likely you're familiar with the PHQ-9, the Patient Health Questionnaire. It does have 9 questions. It assesses the severity of the depression, and it really is a screening tool. Keep in mind, it isn't always diagnostic, because there's a lot of other factors to think about when you're looking at a depression. But a score of 9 or greater has a specificity of 85%, meaning that this is a pretty good number for the decrease in false positives. Sensitivity is 95%, meaning there's more positives, and there could be some false positives, but with a specificity of 85%, that's pretty good. It is available in most electronic health records, plus this is what insurances are looking at when they're looking at their quality, looking at your quality measures. they're looking at the PHQ-9, though there are other screening tools, and I'll review those a bit. The PHQ-2, that's the first two questions on the PHQ-9, and in primary care, we will do the PHQ-2 routinely as a screen, and if there's a score of 3 or greater, then we go on to the PHQ-9 to see what the score is overall to determine if we need to do further assessment for depression. Though a cutoff score of 3 or greater is 90% specific for a diagnosis of depression, though 89% sensitive, so it's a little bit less sensitive for a diagnosis of depression, which is why we go on to the PHQ-9. That's just a slide showing a PHQ-9 with the questions. And you have the slides if you need to read those further, if you're not familiar with it. And then the PHQ-2, really, it's very easy to use. Some organizations are having patients do it like on their portal before they come in. That is a time saver. We haven't implemented that yet. We have the medical assistant give them the, it's easier to give them the form to complete before we are in the room, and actually put it in electronic health records. And our MAs are trained that if it's a score of greater than 2, then it's laminated, and they will turn it over and have the patient complete the 9. There are other screening tools. There's the Beck's Depression Inventory, the BDI. This is a longer tool. It's 21 questions. It is much greater specificity and sensitive for a score of 4, but it does require a fee to use this. I haven't seen this used in primary care, but it's been around a while. I've seen it on some psychiatry reports that I have reviewed, or psychology even, that does some testing. So those types of practices most likely have paid to use the tool. It takes a lot more time, of course, because it is 21 questions. One that you may not be familiar with is the World Health Organization's 5, or the WHO 5. This is 5 questions, and it's kind of an interesting tool because it looks more at the quality of life based upon positive moods like good spirits or being able to relax. Looking at the vitality of a patient, meaning are they active, are they waking up fresh and rested, so it's assessing the sleep, a part of depression, and then just being interested in things. So the questions just are a little bit easier for patients to answer. It's just, but I haven't seen it used, and if any of you have, I would love to hear that at the end of the presentation to see what you think about it. I do have it on the next slide. It is pretty sensitive for depression at 93%, but it really is not as specific as the other tools, meaning there could be some false positives. So of course we would need to follow up a little bit more. So this is the WHO 5, and what I did is I just cut and paste and quoted how that is scored and the questions that are there. It's just less invasive questions. They may not even know why they're filling out. If they may not even know that we're looking at for depression in these questions. Have you been cheerful, good spirits? Have you felt calm and relaxed? Do you feel fresh and relaxed or refreshed in the morning when you wake up? And then just questions about what they do in their daily life. So this is the guideline-based algorithm for screening that the American Psychiatric Association worked with the Institute for Clinical Systems Improvement. This is from 2016. And this is, I just made this, we made this a couple years ago for the primary care clinics at Michigan State to help them helped us work as a team to screen and then follow up for depression, but it's based on the guidelines that are right in Institute Clinical Systems Improvement, or ICSI. So as you can see on the right, if the PHQ is less than 3, it's just entered in, and then a person's rescreened. Remember, this is a screening tool. This is not somebody that already has a diagnosis of depression. That's a different, that would be more monitoring. This is just the screening. And of course, if somebody returns within that year and they're having some possible depressed symptoms, or you're kind of picking up on something, you would screen them again, of course. But if typically screening's done annually, none of the guidelines actually say the frequency, but it seems to be standard of care in most primary care practices. If it is, mild depression, so we're going to keep on to the right, kind of the left of the annual routine screen. Mild depression is with a PHQ-9 score of 5 to 10. And the recommendations for that score necessitate education regarding depression, which again is time sensitive. It takes a lot of time to do that. Offering information that's at their level of understanding, and following up at a time that's mutually decided upon to see how they're feeling, to make sure it's not worsening. Nurses in the clinic can do that. If you have an integrated health system that has behavioral health providers or therapists, they can also follow up with them. You can make a referral. Counseling can be recommended at any level of depression, along with that education piece that I talked about. The College of Nursing is working on a website that patients can go to for the education piece, and we're going to be following that to see how well that's working for patients. So when that comes out and when it's ready, I can share it with Victoria for you to use, because it doesn't have to just be with Michigan State. It's going to be used for anybody. So moderate depression is considered a score of 10 to 14. So starting medications can be standard of care, and then following them up at least 3 times if you're starting medications within 3 months, and then titrating appropriately. So what we are doing is, if it's moderate depression and the provider feels comfortable, having a 2-week follow-up call, either by the therapist or the nurse in the clinic, just to see how they're doing. Because at 2 weeks they're not going to be better, but they may need assistance finding a counselor if they did not want us to make that direct referral, or if there was some barrier with that. Also, we would be asking how they're tolerating their medications, or if they're really even taking them. There are side effects when they first start any medications, and discussing the side effects, answering the questions, and talking about some alternatives and how they are taking those medications so they can tolerate them. And then it's recommended, and what we do is then follow up in a month with the provider, and then following up again a month after that for the 3 times within 3 months. And severe depression is further over on the left, and then we talk about, if they have suicide risk, then we have a different protocol, but that's beyond the scope of this talk. So the best care, the most evidence-based care for depression in a primary care setting is integrated care. This includes having primary care providers and staff working together for the screening, clinical pharmacists being available to help with medication and the appropriate titration or decrease or weaning when it's time, having RN care managers as well as on-site behavioral health providers or psychiatry, Lots of evidence to support it, but and it decreases the fragmentation of care, meaning that they aren't going here for this and here for that, and it's all done in one clinic. And there's something called warm handoffs. So if the primary care provider senses that somebody needs some additional care with therapy or medications, then having somebody right there to assist, and then having that person follow up. That is just the most evidence-based, but as you know, it is the most expensive to have all those professionals there and available. And billing can be an issue as well. This is something that the patient-centered medical home recommends. It is the #1 key function for comprehensive care, and as well as the coordination of care. And I already mentioned about the sustainability of that. There are other models for collaboration where a care manager, which can be an RN or a medical social worker, and the medical social worker really needs to be comfortable in a primary care integrated setting. They are beginning to teach that in those programs, but there's been some difficulty with groups that I've worked with across the state that the medical social workers weren't real comfortable yet understanding the needs in a primary care setting. But there are some fabulous ones that do very well in that setting. And the RN care manager or the social worker, they're utilized to be that point person between the primary care provider and the patient, as well as if there's a psychiatrist off campus or away from the clinic, to help be the liaison between that person, the patient, and the primary care provider. This is based on that chronic care model, if any of you are familiar with that. It's really tough to implement the chronic care model because of all the components, but this collaborative care model is based upon that. Psychiatry in this collaborative care model usually isn't co-located, but accessible, and can be accessible through telehealth even, and they can provide recommendations on medications if the patient isn't doing well or not meeting the goal. They also can help with alternative diagnoses, because there are something like bipolar disorder can present as depression, but really the diagnosis could be bipolar disorder instead of depression, and the treatment would be different. And that's when the psychiatrist could be helping with a primary care provider. And in this model, the care manager is the one that's speaking to both of the providers, the psychiatry provider and then the primary care provider. And there's ways to set up EHRs to have that communication between the two providers. It has shown effectiveness in improving outcomes. Again, reimbursement's an issue, especially for the psychiatry piece. How do they bill for that? It's just difficult, but I do see that in some of the literature that it is going to be the future as more and more people are screening, and then of course having that diagnosis of depression. Of course, the barrier is having enough psychiatry providers. It is a need as well for psychiatric mental health nurse practitioners. It's a great need for those that can help with screening as well, not screening but treatment. So you may not have resources for either of those programs. We don't. So having the workflow for follow-up and access to behavioral health resources, if the screening is positive, is needed. Mild and moderate can be effectively treated in primary care with the education piece that I talked about, helping them with self-care and referral to psychotherapy. It's difficult for patients, especially depressed, anxious patients, to initiate the counseling or behavioral health services themselves. At one time, we were telling patients, well, just call the number on the back of your card, and you can get counseling, and they'll tell you where to go. that just was not effective. And so we developed a referral process. What I did was pretty much call every counseling service in the greater Lansing area, and some of the rural areas, to find out what their insurance panels are for the therapist. And I developed and I didn't do it myself, it was done as a team, but we developed just a book, really, of community health providers, what they specialize in, what age group they might see. And this is pretty much like a behavioral health network. In 2 weeks, we've invited pretty much every behavioral health entity in the Tri-County area to a behavioral health fair where our primary care providers can actually meet them face to face. And the hope is to improve that collaboration, because we're still missing that piece of collaboration between behavioral health and primary care. We just kind of take it from the patient whether or not they went and are in therapy. So developing the network I kind of touched upon, but really getting to know the area that you're in, what's available. The word does get out that you're trying to develop more of a network to work with your primary care providers. They want work. They want to be able to serve the population that they've been trained to do. But when you do start to make this directory or catalog, you need to know what they're licensed in, their qualifications. Do they work with a psychiatrist? Where are they located? Because you want to be able to make it accessible for the patient to get there. Are they on the bus line? Like I said, what's their insurance panel, or do they only take cash? What about their wait times? And then, some psychotherapists or behavioral health therapists focus on particular populations, older populations, children, ADHD. Some are more culturally sensitive and want to focus on that, or spiritually focused. Again, I talked already about the direct referral process using that behavioral HIPAA form, so hopefully that will be announced soon. And then just setting up the network with educating your staff, especially the staff that will help with the referral process, emphasizing the importance of initiating and following up on these referrals, having the staff follow up to make sure that the patient still wants to go and has gone. And you still need the primary care provider in the clinic to follow up as well with positive screens. And that connection to behavioral health, as I mentioned, and I already talked about the fair. So these are some resources. There's resources on the MIPS quality measures. There's resources through the lexicon, which is on the Agency for Healthcare Research and Quality site. This is an excellent tool for implementing collaborative care. There's an example of a referral form for behavioral health services. We've designed our referral form based on this community care from North Carolina. So it just states what it's like the diagnosis and why we want, what we're hoping for from the therapist. And then there's an example I listed there for communication back to the primary care to improve collaboration. There's also a flow chart. There's lots of different things. We use this Columbia Suicide Severity Rating Scale to assess for suicide. It's evidence-based, and you can find it there in my references. So I think I gave 10 minutes for questions, if there are any.
Yep.
Take a drink.
So we'll now open the lines for comments and questions. So please state your site name first and then ask your question. So are there any audio or video sites that have any questions? Are there any questions or comments? Okay, if nobody has any questions or comments, or if you think of one later, you can always indicate it on your evaluation and I can pass it along to our presenter, or you can email it directly to me and I can pass it along to our presenter that way. Thank you for joining us and have a great day.